Welcome to this week's Nurses Inside and Outside the Classroom. At some point, all nurses were students. And eventually, some nurses become educators, but a great nurse always remains a student and an educator. This week, we're going to take a look inside the delivery room, and we're going to take a look at the fetal monitoring system. Fetal monitoring systems are important because they let us know if the fetus or mom is in danger and if nurses need to intervene. There's two systems that you sometimes can see in the hospital. One's an external system. And with this system, you'll see two belts wrapped around the mother's abdomen, and it holds in place what we call a toco. With this system, we are able to measure the contractions and the fetus's heart rate. But if their complication arrives, then what can happen is extra movements from the mom and from the fetus may interrupt our assessments, and it's no longer accurate. And then we'll turn to what's called an internal electronic fetal monitoring system. Some of the complications that may arise is if, let's say mom had a stillbirth in her previous birth at 32 weeks gestation or longer. Or let's say she's having a complication like preeclampsia or eclampsia, placenta previa, among other medical problems. Maybe we're inducing labor, specifically with oxytocin. Maybe she's preterm right now. Perhaps we're trying to attempt a vaginal birth when her last pregnancy resulted in a cesarean. Sometimes when these complications arrive, we have to take a better look at what's going on with the fetus. So with our electronic fetal monitoring, this is the equipment basically that's going to be getting used by the doctor and nurse. As you can see, we have an electrode coming here, and we have this spiral-looking thing at the end. Now, four things must take place in order for us to attach this electrode to the fetus. The first would be that the mother has to be dilated at least 2 centimeters or greater. So the doctor or nurse would check and see if the cervix is dilated. And if the cervix is dilated, the cervix also has to be ruptured. And if the membrane is not ruptured, then the doctor or the nurse will rupture the membrane in case of emergency. Also, we have to know exactly where the fetus is positioned and what body part is presenting. Best case scenario, we have a vertex presentation. Once we know what fetus body part is presenting, then we need to make sure that it is against the cervix. We would take our electrode, using sterile technique of course, and we would then place it against the fetus's head, and we would turn it clockwise, embedding the spiral electrode into the fetus's head. And this gives us a continuous look at the fetus's heart rate up on a monitor. We have a wire come off the electrode that would attach the mom's thigh right here, and then that wire would go off into our monitor, and that would give us a picture of it. Now what we're looking for is a baseline of fetal heart rate. In a perfect world, we'd get a 110 to 160 beats per minute. But sometimes the heart rate falls below that. That's called bradycardia. Bradycardia can be an ominous sign, which means that danger is coming. But usually it's benign. We're mainly concerned with tachycardia, and that's when the heart rate moves above 160. If it hits 180, we're in marked tachycardia, and we need to intervene immediately. Nurse Peggy's going to go over different variability that we're going to see with our baseline.
All right, with baseline variability, what it measures is the push-pull or the interplay between sympathetic and parasympathetic nervous system. It's measured over a 10-minute period of time, and what it's going to measure is irregularities in frequency and amplitude. There are 4 different categories with the amplitude. Absent means the amplitude is not detectable. Minimal means the amplitude is slightly detectable with 5 beats per minute or less. Moderate, the amplitude has 6 to 25 beats per minute, and marked is greater than 25 beats per minute. You can go to the next one. There are different things that can increase or decrease the variability. Things that decrease the variability are hypoxia or acidosis. This is where the fetus is not getting proper blood flow. Drugs that decrease the CNS system of the infant, like Demerol, Valium, Visatril, that's correct. The infants go through a sleep cycle that usually lasts 20 to 40 minutes each hour. That can decrease the variability. Gestation of less than 32 weeks. The fetus CNS system is immature to regulate the heart rate, and anomalies that affect the heart, the CNS, and the autonomic nervous system. With marked variability, you have an increase, and things that cause that are early to mild hypoxia. The fetus is trying to compensate for the condition. Fetal stimulation or activity, like abdominal stimulation, the mother's having a pelvic exam, or else you're doing acoustic stimulation. Another factor that can cause marked variability is the infant's breathing movements. The last thing that will cause marked variability is a gestational age of over 30 weeks. It's one thing that you do need to keep in mind. Absent or minimal variability not caused by fetal sleep cycle or CNS depressant drugs is an indication of ominous fetal status. Mike?
All right, and what we're looking for is the acceleration with the fetus. And Nurse Sherry's going to explain what that means.
Yes, this is when the fetal heart rate is in sync with the contractions. And this is showing fetal health. This is a normal procedure.
This is what we're looking for, is what we want to see. This
Yes.
is ideal. Here's mom down here, here's fetus up here, and they're in rhythm with one another. The fetus is having an increase in their heart rate when the contractions happen. Sometimes, though, we don't always get what we want, and we get sometimes what's called an early deceleration.
Yes, early deceleration is when the fetal heart rate drops down at the beginning of contraction. That's when the head is compressed, causing cerebral blood flow to cease just ever so slightly, causing the vagal response. And it's really not very concerning at this point.
So we see here we have moms having contractions here, and the fetus is having a deceleration versus an acceleration. Nurse Deborah, is there any interventions that we can offer to fetus at this time?
For this situation, an early deceleration is considered a benign event, and from a nursing perspective, there are no additional nursing interventions. However, we would continue to monitor the fetal heart rate.
Okay. The danger here is that an early deceleration can very quickly turn to a late deceleration. And with a late deceleration, this is what we have.
Yeah, in a late deceleration, you're going to have the fetal heart rate drop at the ending of a contraction. And it's due to a uteroplacental insufficiency. Most of the time it's from the hypotension from maybe anesthesia of some sort, or possibly like the oxytocin. And usually that's when the fetus, if it continues, that's when the fetus can become in trouble.
Okay. So here we have mom again. She's having a contraction. Fetus having a late deceleration. There's no rhythm between the two. Nurse Deborah, what are some interventions that we can offer the fetus at this point?
With a late deceleration, there are definitely certain nursing interventions that you want to take place. The first one would be to administer oxygen via a face mask at 7 to 10 liters per minute. The second one, you'd like to take the mother and you're going to turn her to her left side. Going to maintain hydration, and that'll be either with normal saline or lactate ringers. If the mother is on a oxytocin drip, that will stop. Finally, the doctor more than likely has ordered a blood sample test from the scalp of the baby, and what you're going to look at is the pH level. If it's 7.25 or higher, you're going to continue monitoring the nursing interventions that you've already put in place and continue monitoring the fetal heart rate. However, if the pH level is 7.2, which is acidic, then you're going to prepare the mother for a imminent birth of the baby because the baby is in trouble.
And sometimes we have more complicated situations, and that's called a variable deceleration. Nurse Sherry?
With the variable deceleration, the fetal heart rate becomes, it's variable in shape and size along with the contractions. And that's due to compression of the umbilical cord, either due to prolapse or being wrapped around the baby's neck. There is no blood flow or lack of oxygen between the placenta and the baby.
Okay. So we have here, mom is having a rather large contraction here, and the baby is actually, the heart rate is dropping down to 15 beats per minute. That's what this is here. So the baby's in some serious trouble here, and we need to intervene. Nurse Deborah?
All right, this is a more serious situation. So the variable decelerations, of course, you're going to have the oxygen. You're going to turn the mother to whichever side or which position increases that fetal heart rate. So it could be left, right, whichever position increases the fetal heart rate. You're going to absolutely stop the oxytocin drip. The doctor may or may not order pH level testing at this time. The difference is that you're going to do a pelvic exam and you're going to actually look for a prolapsed cord or some significant change in the labor process. But most importantly, in this situation, you're going to prepare the mother and the family for a most likely cesarean section.
All right, well, that will conclude this week's Nurses Inside and Outside the Classroom, and we'll see you next week.